This is forward.
Okay.
And this is a pointer if you need.
Pointer.
Okay.
Okay, thank you. Good morning, ladies and gentlemen, Chairman, Mr. Chairman, dear Pascal, thank you for giving us the opportunity to report about our experience in this topic. Actually, my lecture, the aim of my lecture is double. That is, first to provide you with some information about what we call our certification process in France, and then to probably more interesting for you, to show you the data extracted from our feedback database. And as you will see, all these data were considered as a strong incentive to implement and to launch the FUSE program in France. Interestingly, I would say that coming at the very end of this course, in some ways, this data will show you that all these adverse events which were talked about all this morning do occur in operating rooms and with the energy sources. Reporting system in healthcare organizations stem from a desire to achieve a level of resilience and response to errors and adverse events that has been achieved in some other activities, like, for example, here, of course, aviation, but interestingly also in some iconic building sites, like, as you can see here, the reporting is considered as a safety rules at the same level of priority that wearing hard hats. And so I think that we should think of implementing all this reporting system in our activities. About certification, what we call certification, it's a feedback-based voluntary risk management initiative, and the scheme is quite simple. As doctors report adverse events, these adverse events will be analyzed by experts, validated, anonymized, and stored in a database. Then the database is analyzed by the experts, and this analysis produces guidelines that doctors have to implement in their practice to improve the safety of their practice. Reporting is not the only part of certification, as doctors have also to take part in some activities in their specialty safety improvement programs, that is evaluation of their practices and continuous education. The target populations are all surgeons, all surgeries, whatever the specialty, gynecologists and obstetricians, dental surgeons, ENT specialists, ophthalmologists, anesthesiology and ICU, and some medical interventional specialties, some like cardiology, radiology, and also gastroenterology. The architecture of the disposal is one approved body per specialty. Important, the program is peer-led, that is what we call experts are actually practicing specialists who had 3 days training by the Haute Autorité de Santé. There is an incentive for doctors with a private practice that who receive a contribution towards their insurance premium. The certification allows doctors to fulfill their CPD requirements, and important that all the results of certification are made public on the Haute Autorité de Santé website. On December 2015, there were 18 approved bodies, nearly 9,500 certified doctors, and more than 83,000 adverse events analyzed and stored in the database, which started in January 2009. As regards the Fédération de Chirurgie Viscérale et Digestive, which is the approved body specially devoted to our specialty, we have already produced a lot of guidelines, as shown here, and the energy sources in the operating room is one of our new topic as for guidelines. Before reporting the data extracted from our database, I must underscore the fact that as it is a voluntary declarative reporting system, of course all our data are of known epidemiologic value, of course. So starting in January 2009 and until December, end of December 2015, we have collected in our database 876 events directly related to the use of energy sources and devices in the operating room, as we have around 800 surgeons. That means that 800 surgeons report more than 100 events, adverse events per year during these 7 years. A large number of events related to the monopolar instrumentation, and in bold, the 3 topics I will detail further. That is monopolar, of course, tissue shielding devices, 137, and ultrasonic devices, 69 devices. You can see here 24 events directly related to cold light sources, which is actually not that cold. 614 adverse events related to the monopolar device. Of course, it's the most often used device. And when analyzing the reports from doctors, we have very few information about outputs, which might be interesting, of course. These 614 adverse events are scattered between fires, insulation failures, skin burns, and visceral injuries. Fires in the operating room, 98 reports directly related to the use of alcoholic-based solution for skin prep, and particularly with no attention paid to warning information, particularly to the advice of a thoroughly drying of the solution before putting the drapes. So today we have more than 100 events. Insulation failures, 139 reports. These adverse events were reported exclusively for lab instruments, and important, as mentioned before in several presentations, that all these events occur off the view of the surgeon, that is outside of the field of the camera, and this might be a cause for reoperation, as we will see further. The root causes for these problems is probably in part economic, that is using reusable devices, where we all know that the sheets of this device can be scrapped on the metallic part of the trocars. Another potential cause is the use of outsourcing for sterilization, where we had some proof that there was a failed checking of instruments when preparing the operating boxes. And some years ago, I heard during a presentation before that 20% of instruments were supposed to have insulation failure, but actually in France we did, with Jean-François Gavier some years ago, a test between different hospitals, and we had more than 20% as during our test. And we have some people use preoperative testing, but this testing is seldomly performed. Skin burns, more than 200 reports, different causes reported, a problem of inadvertent activation of the surgical device, which can be related to pedals positioning, failed monitoring of power source, of course, some cases related to a deactivation of the alarms, Surgeons discovering new instruments during an operation, and when using this new device, they don't know precisely how to use it. And faulty application of dispersive electrodes were directly related with some cases. So the fourth slide about monopolar electrosurgical devices is directly related to visceral injuries. And as you can see, we have a large number of reports about visceral injuries. Some causes were not mentioned previously. That is, for example, in some positioning of the patient, the intestine is at increased risk of being hurted by introduction of the instruments. And as you can see here, the intestine is at more risk of injuries during this introduction of instruments. About tissue sealing devices, we had 137 reports with post-operative hemorrhage. I will make a comment in the next slides. A large number of urinary injuries reported particularly in gynecology and gynecologic surgery, and with a large number of injuries to the ureter and during hysterectomy and gynecologic surgery. Some intestinal injuries, common bile duct injuries related to tissue sealing devices. This is a comment about these tissue sealing devices. Here it is an advertising of, for example, for the B clump, where are underscored two so-called advantages, and advantages that I would maybe comment as fallacious, you know, because first of all, when you look at this, the coagulation of 7 millimeters vessels, you must know that these vessels, these tests are performed on healthy animals and with, of course, healthy intact vessels and not with potential arteriosclerotic tissue, vessels, and the possibility to coagulate, to seal these vessels might be different when you use it for human arteriosclerotic vessels. A second comment is that on this advice, as you can see, the fact that the use of the B clamp can be used without dissection of individual vessels is, in our view, particularly questionable, and a large number of the ureter injuries I have reported before were directly related to the fact that coagulation were used without a correct dissection, and this might be considered as a true risk in the practice. As for ultrasonic devices, same number of hemorrhage and digestive injuries, a small number of ureter injuries, and all these injuries were associated with a need for unplanned reoperation, nearly 150. And as you can see, the data scattered between all the type of devices as cause of unplanned reoperation. And as for the causes of this reoperation, urinary injuries appears at the highest level, but if you combine small intestine and colonic injuries, actually you achieve nearly the same number, and the three main causes are here. So our conclusions were that when analyzing all this data, there was an underestimated morbidity associated with energy sources in the operating room. We noticed that most of these events were directly related to reckless behaviors and a lack of information, of knowledge, some problem of maintenance as well. A specific fight is that the surgeons often discover new instruments intraoperatively, and this is problematic because there is an aggressiveness of the commercial task force which pulls pushes the surgeon to the risk of adverse event because they have to discover the use of a new instrument while performing an operation. And so at the end of the day, we considered that because of all these adverse events, we had a strong need for implementing and launching a continuous and initial education about the use of energy sources. And that's why we decide to contract with your FUSE program and to implement it in France. I thank you for your attention.